Good afternoon, everyone, and thank you, Simon, for the introduction and the great presentation. I did have a question, even though I put my hand back down, and maybe we'll talk about it in the discussion section. But my question was, and it sort of follows up with the next steps. I assume it's the government that's funding these universities, and the government has a great interest in getting quality CE out there. Could the government put pressure on these universities to collaborate economically?
At a broader level, yes, they could. At a broader level, I guess, yes, they could.
Scream.
At a broader level, I guess they could. And but the issue we faced was they didn't know what continuing professional development was. So we had to educate them from the very beginning. Yeah.
Thank you for that. So I was thinking about, as Simon was presenting, I was thinking, and one of the things that came to my mind was an old Sesame Street song. Do you remember Cookie Monster had 4 dishes with cookies on it, and he said, "One of these things doesn't look like the other." Which, remember that? Well, I'm not that person here today. I'm a bit of an outcast today, in the sense that you're all academics and you're all obviously very involved in the CE community. And my level of experience in the continuing professional development community starts today. Even though I've had 20 years of experience in the patient advocacy community, sadly, I think the advocacy community has missed an opportunity, I would say, to get involved in continuing professional development, because it's not something that's ever talked about in the community. It's not something that's ever discussed or published. And in preparing for this talk today, I got to say, this is one of the tougher talks to prepare for, because this is not what I usually talk about. And so I started researching, well, what's out there? How do patients benefit from continuing professional development, high quality? And obviously, the answer is that they get better medical care, right? That's the obvious answer. But I was tasked with coming up with some examples of non-economic ways that CE may or may not benefit patients, or CPD may benefit patients. So I've been in the advocacy community for nearly 20 years, following the death of my parents, sadly 2 days apart, from 2 different cancers. And that was in my mid-30s, and immediately was launched into the patient world because of what I perceived as needs out there that weren't being met, more so than as a tribute to my parents. And I was really proud that we were the first organization, the first patient group that ever was formed for colon cancer in this country. And that experience of directly communicating with patients, because as you're a small nonprofit, where we started, you're dealing with patients directly. And so I had to come up with some ways that those experiences would translate into non-economic value to continuing professional development. And it wasn't an easy task. But what I came up with was 12 points for really discussion, not points that are true, not points that are evidence-based or research-based. They're really based upon my personal experience, watching my parents go through a cancer journey, as well as all of my work with these various organizations that you see up there, and dealing directly with patient groups and patients over the last 20 years. So we know that we start from the basic premise that patients need their healthcare providers to know the latest information about their disease and illness. That doesn't really warrant discussion. We all take that as a basic premise, that high quality continuing professional development must translate into better quality measures for patients and better outcomes for patients. And so we've already heard about the great potential economic benefits from high quality CPD, but what about these non-economic policies? Usually when I'm speaking in front of regulators or healthcare providers or some other stakeholder group than this one. And what I usually talk about is how patient-centeredness is the most important policy consideration as regulators tackle which drug to cover or not cover, or which policy to enact or not enact. And I always advocate that if you just keep the patient in the center of your mind as you're developing that policy, the policy will be a good policy. And I think that works also in CPD, because if all CPD, and I know this goes against everything this conference is about because we're looking at the economics, right, of CPD, but if we look at keeping the patient at the center of the CPD, not economics, then I think you're going to get a much higher quality CPD program and that will much more greatly benefit the patient. So I put together these 12 things. Again, these are discussion points. These are, again, based on my personal experiences and not research-based. But what I thought first was that CPD should increase patient knowledge about their disease and treatment options. So that sounds pretty basic, but from my work in the nonprofit world, I'll tell you that we fight to get patients to come to us for information. We create these great websites, we do programs, we do educational conferences, we do newsletters, we do all these different communications tools to get patients to come to us for unbiased information. But with all that effort, where do they go? They go right back to their doctor, and they listen to their doctor. And that's been the case for many years. So despite all the efforts of increasing patient knowledge outside of the doctor's office, the truth is that most patients still go to their doctors and still follow those doctors, their doctor's recommendations. And so we would hope that the CPD increases the patient knowledge about their own disease and the doctor's ability to translate that information to the patient. CPD should always teach physicians or healthcare providers to keep patients comfortable. Now that sounds pretty basic, right? Comfortable. What does that mean, though? It could mean comfortable with their understanding of their disease, comfortable with the treatment of their disease, comfortable with medication management, things of that nature. CPDs have to ensure that healthcare providers are a reliable source of information. So today, what we hear about all the time at medical conferences is about Dr. Google. So patients come into the office after seeing Dr. Google on the internet and learning everything they need to know about their disease, and they come in as this new informed patient, different than it's been traditionally. And we have to make sure that healthcare providers stay on top of the diseases, stay on top of the latest information, and have the highest quality understanding of not only what the medical journals are saying, but what is the internet saying? What are other people talking about? Because they're going to be discussed at the doctor's office. And so CPD has to make sure that healthcare providers have the latest and greatest information. And then we talk about patient preferences. So frequently, patient preferences may conflict with other stakeholders' preferences. For example, I go back to when my mom was diagnosed. Most stakeholders, she was battling metastatic cancer. She lived for about 10 months after diagnosis and was in and out of the hospital multiple times for various reasons during her treatment. So my mom was a little bit different than maybe your average patient. Maybe your average patient can't wait to get out of the hospital and get home and be with their family and get away from the healthcare setting. And maybe most patients feel that way, and most stakeholders certainly feel that way. The payers want the patient out of the hospital. They don't want them to get infections in the hospital. It's expensive to be in the hospital. But in my mom's case, she felt safest in the hospital. So when she was at her sickest or at the end of life, her preference was to be in the hospital where she could get access to great care, great therapies, pain management, medication management. And so maybe sometimes, even though all other stakeholders have a different interest in getting that person out of the hospital, and this is just one example, sometimes the patient preference matters, and sometimes the healthcare providers have to understand that, even though it may conflict with their goals. So I talked a little bit about recognizing that patients are informed. I won't repeat that, but patients are different today. And it is all about Dr. Google and about, hey, my friend had that cancer and this one. What about, I read about that clinical trial that everybody's being cured for, so doctors complain that they're spending half of their visit now disproving stuff that patients come in with them from the internet and from other places. And they have to recognize, and they have to be able to encourage that dialogue. Because I was one of those people. When my mom was diagnosed in 1998, internet was brand new. There was very little information about colon cancer back then. But I found some, and I ran in there on her first visit with a list of about 20 questions. And I could picture his face today, almost rolling the eyes and huffing and puffing. No, that's not for her. No, she needs systemic chemotherapy. That's not for her. And he was just annoyed. And so I think there's an opportunity for healthcare providers to be aware and be patient with the person who has that disease, who's coming to them for care. The other thing I came up with was that CPD has to teach the value of the patient's time. again, going back to my mom's story, when she would go for a chemotherapy treatment, she would arrive at 8 or 9 o'clock in the morning, and then it was blood tests, and then more tests, and then wait for the results of the test, and then finally her infusion. And, it was an entire day for a 1-hour treatment. And I think health systems and healthcare providers have to take into account that the patient's time is very valuable and it shouldn't just be ignored. CPD should encourage clinical trials where appropriate, and that's another place I think CE, continuing professional development, fails, is that we know that most patients receive information about clinical trials from the healthcare providers, and we also know that the vast majority of healthcare providers don't even discuss clinical trials with patients. So from my perspective, from the advocate's perspective, that's another important area where CPD can affect patient care in a meaningful way. And CPD has to recognize that the patient isn't the only one affected by a disease or an illness. A major disease, a cancer diagnosis, doesn't just affect the patient, it affects the whole family. It affects the caretakers, it affects the employer, it affects the children, the spouse. There's a whole community of people around the patient who gets affected, and doctors have to recognize that and recognize the value of everybody's time and everybody's concerns for that patient. There's only 4 more. CPD should consider the impact of treatment on non-medical issues. So what about the ability to work? So you may follow NCCN guidelines and give the patient that course of chemotherapy that's recommended, whether or not it'll work for a month or a year. But what you're not taking into account sometimes is the effect that that treatment may have on a person and their family and their livelihood, working and things of that nature. So maybe a better dialogue with the patient, fully understanding their treatment and the impact that treatment may have on their life would be appropriate. We talked about considering the caretaker, recognizing that patients are unique and that a one-size-fits-all approach doesn't work. Now, that's something I use in a lot of my talks, and usually it's with regulators and policymakers, because we're moving to an area in medicine, it seems to me, where governments, payers, policymakers are all looking to come up with a one-size-fits-all approach, a recommendation for all patients with that disease, and if it cuts costs, that's a good thing for the medical system. And that's the way things have been going around in Europe and Latin America for a number of years, and that's slowly coming to the United States. But we have to remember that a one-size-fits-all approach doesn't work for everybody. You take a patient with unique disease like a lupus patient or an autoimmune patient or rheumatoid arthrology patient, your standard guidelines don't work for each patient. And so physicians have to remember that each patient is unique, each patient has unique needs and a unique body, and that a one-size-fits-all approach doesn't work. And CPD should remind doctors that patients come before economics. Find a way to pay. And that's going back to the example of my mom. So most guidelines would say once the patient is stabilized, they have to leave the hospital. It's very expensive to stay in the hospital. But what about patient preference? What about that my mom felt best in the hospital setting toward the end of her life, even though it was very expensive to be in a hospital? Does it mean that because payers don't want to pay that, we should just ignore the patient preference? I think that CPD, high quality CPD, should address that. And maybe we need to find a way to pay. Maybe if the payer doesn't want to pay, a nonprofit should pay, or the patient could pay themselves. But patient preference really has to come into play. And I think the CPD is a good forum for doctors for healthcare providers to follow. So what are the guiding principles? Really, the patient must always be the central focus of the HCP's professional development. Must always be the center, not economics. Everything else you're learning for these 2 days is wrong. It's all about the patient, not the economics. Sorry, I'll never be invited back now. But why is that? Why is that true? It really comes down to one thing, because all of us in this room someday are going to be a patient. If we haven't been already, we're going to be someday, unless you die suddenly. Or your parents are going to be, your spouse is going to be, your children are going to be. Everybody's going to be a patient. And this is something I'm always hammering at regulators as they're hammering the patients away with their policy decisions. I always say, don't forget, you're going to be a patient someday. So That's really my take on it. Try not to throw any things at me because, again, this is not evidence-based. This is what I was asked to talk about and share my personal stories, and so I've done so, and I thank you for your time.